Hi, and welcome to SpondyCast, where we bring together the best medical minds, thought leaders, scientists, patients, and caregivers to inform and inspire the spondylitis community. I'm your host, Jill Miller, living my best spa life, knowing that how we meet today has the power to change everything going forward. Hi, and welcome to SpondyCast. Today, I am very pleased to say our guest is Dr. Tran. He is a board-certified internal medicine doctor, fellowship-trained rheumatology at the University of Southern California. He has also obtained advanced dermatology training in the United Kingdom, earned both master and diploma with merits of practical dermatology from Cardiff University. Dr. Tran is an assistant professor of medicine, rheumatology, and dermatology at California North State University. He is also a preceptor for University of Southern California PharmD residents at 986 Pharmacy WMC residency program. And I'll mention he is a Facebook and YouTube influencer with over 300,000 followers. So, Dr. Tran, we are very excited to welcome you here today.
Hello, Jill. My pleasure to be here. My pleasure to talk about spondyloarthropathy.
Yes, so we're going to talk about that, and we're going to talk about it through the lens of a word that many of us probably know that the general public doesn't know, but we should get into it. We're going to talk about the role of DMARDs in treating spondyloarthritis. So first, can you tell us what DMARD means and also the different types that are out there? And then we'll get into it. We'll get a little background first.
Sure, Jill. So DMARDs, or disease-modifying anti-rheumatic drugs. So long names, but you call it DMARDs. They are a class of medication commonly used in the treatment of spondyloarthropathy. This is a group of inflammatory rheumatic disease that primarily affect the spine and the SI joint. Now, DMARD has served as an essential component of the treatment regimen for spondyloarthritis by targeting the underlying inflammatory processes and help to manage symptoms. So in short, those drugs that magically find a way how your body was inflamed and try to reduce those inflammation pathway. At the same time, to prevent joint damage, to relieve pain and symptom, and to control all the extra articular manifestation of the disease. So they're very strong. And we have so many DMARDs out there. And I'm not sure. Jill, do you want me to go over some of them, or how should we?
So I think there's a few buckets, right? So I think of them as steroids, methotrexate, and is it sulfasalazine?
Mm-hmm.
Are those the three buckets that are most popular?
Yes. Jill, you are the expert, but let me share with you a bit more. The way that we classify them, we divide into three main groups. The first one we call conventional synthetic DMARD, and those are the ones you just talk about: sulfasalazine, methotrexate, hydroxychloroquine, lefonamide, azathioprine. So those are the conventional, the one that perhaps you heard about them all the time, or because they've been existing longest. The next we call biologic DMARDs, and those are tumor necrosis factor inhibitor. Now let me go back and share with you what is tumor necrosis factor, or TNF.
Yes.
Whenever one of our cell injury, okay, if you and me get injury, Jill, what we're gonna do? We're gonna yell, we say, hey, I'm in pain, right? And we're going to send a signal to other cell or to other body, ask for help. So TNF, we can see as a signaling between cell whenever they inflame. And what they do is they send out those signal, and more cell come over to help to control the inflammation and to make the cell more inflamed. In order to control the inflammation, one of the way we inhibit we stop those signaling pathway. So we call it tumor necrosis factor inhibitor. Well, the name
So
sounds very right.
are you saying when we have a cell that asks for help, the
Mm-hmm.
other cells that come are what's creating the inflammation? Is that
Yes. But the problem with spondyloarthritis is they miscommunicating. They send out a wrong signal. They send so many signal out there, and then those cells just keep coming back and attack ourselves. For
right?
example, instead of attack bacteria or viruses, we attack ourselves. So that's what we call autoimmune disease, autoimmune ourselves.
And this is what was happening during COVID when people were having cytokine storms, right?
Exactly. That's what it
Okay.
is.
So those, and for anyone who's not listening, those were when we were hearing about people with all of the lung issues where their lungs were filling up. And
Yes.
that was because we didn't know what was in our bodies and we were screaming for help, or our cells were screaming for help and the cytokines came to help, but they helped a
Yes.
little too
Yes.
much.
Yes.
Okay. And that wasn't for AS, but I always think of that's when inflammation became mainstream, or sort of like,
I like it because that's how I explain to my patient too. Think about your body as a country and the immune system like an army. We have the navy, we have the air force, we have whatever out there, right? What happens if the army themselves don't fight with foreigner? We fight among ourselves.
Civil War.
Yeah, a civil war. Basically, that's what it is. You don't want that, right? So
Right.
our news is a kind of civil wars in our body. Now, in order for those signaling continue between cells, there's a TNF, and how do we stop them? We call it TNF inhibitor. So those are the cell, and those are neurobiologic DMARD. And you perhaps you hear all the time those are interleukin inhibitor, particularly interleukin 17, secukinumab or izokizumab. You may not remember those names, just forget it. But those are the interleukin inhibitor. And the other
Those
one,
would be branded
yes.
biologics.
But if you pay attention, Jill, I would not mention any brand. I try to be very
That's
gentle.
fair. I'm just translating that.
Yeah, I can tell you, I give many talk, and with my experience, I usually I don't mention any brand.
Yeah.
Anyway, the other one I my favorite we call interleukin 12 slap 23, or ustekinumab. So this is the one that target both IL-12 and IL-23. So think about those signaling pathway, and we inhibit them, so they stop. So the inflammation pathway or cascade stop at the beginning. So no more cell damage, no more joint injury, and no more cartilage damage. And that's how hopefully we can control with the neurobiologic DMARD. The last DMARDs we call target synthetic. You may hear about this on social media or radio too. One of the famous one we call Janus kinase or Jack kinase inhibitor. Perhaps you know about this too,
Yes.
Jill.
We've
Yes,
heard about JAK inhibitors.
it's a very famous one, and the two of them are tofacitinib and baricitinib. Those two are the most famous one because they has been studied extensively. Now, they really control symptom well, and they are considered one of the good drug out there. However, with three classes we just mentioned, the conventional, the biologic, and the target one, we have now a forehand of tool we can help with patients. And hopefully those DMARD can make a strong impact on our patient life. So those are very short one, and I mean long history short, but those
Yeah.
work had been developed for years, and methotrexate, sulfasalazine, and perhaps one the oldest one is called plaquenil or hydroxychloroquine.
Sure.
Those back in 60s, 70s, 80s, so long time ago. And biologic just recently in the past 10 to 20 years, and the target one in the past 10 years. So you
And
can see,
I'm
yes,
sorry. And do steroid, where do like corticosteroids or Or
Oh, steroid, I consider one of the DMARD too, but I consider the way that I mentioned to my patient, I try not to use steroid long term.
right.
So this is one of the way that the ACR in general, we do not recommend use steroid more than 3 months because even though a very low dose, right? In the past, we think, oh, what I use only 5 mg per day, but actually, a few studies from the Europe prove that even a smaller or lower dose, we still have some potential long-term side effect.
Oh
So
yeah. I
technically, they are demarcated, but I don't want to make the indication that people may use for long-term, such as other
So
demarcated.
that's a good distinction, right? So my understanding is the steroids are generally an acute situation. In my experience, I can't speak for anyone else, but I know that I get about one dose a year where I'm allowed to call and say, like, I'm so miserable, help me. Uh, and I get a 5-day dose and that's it. And I have to wait until the Christmas.
Well, the way that I explain to my patient about steroid, think about your body is a house, and if you have joint pain, you inflame. So a house is in fire, right? So
Yeah.
steroids are the distinguished fire equipment that can really stop the fire right away. However, in order for you to control the inflammation from inside, you need other tool. You need some chemical, you need like insulation, you need other things to protect, to control the inflammation, not just to control at the same time. So you
Okay.
need two drugs, right? The one that stop inflammation right away, acutely, but we should not use long term. And the other
Okay.
one is control the inflammation long term.
So a steroid's like a fire extinguisher, and a DMARD is like insulation.
Yes, that's
The conventional DMARDs. Okay. So
it.
let's talk a little bit about the conventional ones. Uh, are they used in conjunction with other treatments?
Yes, you can use. Okay, first of all, let's go back to this. Whenever we think about GMR, we think about a group of medication, and yes, they can use in conjunction with many drugs, and not just one particular GMR or steroids. The
Okay.
decision choose, however, depends on many factors. For example, the disease severity. Some of them could be very severe. Perhaps you see some of them. Some of them just so mild. So the combination therapy, usually the choice depend on patient specific conditions, disease activity, and then lastly, response to therapy. Some patients, they may start with one particular GMERD, some class, but it doesn't help. So what they do, we move to a different class or we move to a different target. Like I just told you, right? We have the conventional, we have the biologic, we have the targets. So it depends. We can also combination DMARD with NSAID. Perhaps someone or you already know about NSAID. It's a non-steroidal anti-inflammatory drugs we use to manage pain and inflammations. Now, we can use DMARD with physical therapy. I'm not sure if you ever entertained
Oh,
that idea.
DMARDs with physical therapy.
Yes, why not, right? So this is what I do in my practice because physical therapy and exercise are important component of the spondyloarthritis management. And DMARD can help reduce the inflammation and pain, make it easier for individual to participate in physical therapy and maintain joint mobility. Now, we can combine DMARD with biologic DMARD, right?
Yeah.
Basically, same or some classes. We can combine DMARD with corticosteroid. I just told you, right?
Mhm.
The acute flare, yes, you can use a little bit, or sometimes you may use strong high dose of prednisolone or prednisone, and then when the condition is better, we go back to DMARD. So in summary, the choice combination therapy, Jules, it individualized. and the specific medication used together will depend on the patient unique circumstances. And
Right.
the rheumatologist will carefully weigh the potential benefits, risks of the combination treatments, and then they will make the best decision when we discuss with our patient.
And are there any groups that traditionally would not use DMARDs, whether it's age or pregnancy or nursing?
Yes, yes. And those are, so first of all, few group or few subset of patients that I will consider very careful, or some of them I would not know use at all. And perhaps you know some of them already, use.
The people who wouldn't use them at all?
Yeah. So let me show you a couple, share with you a couple of things that we recommend no use or use with very careful.
Okay.
Yes. So the first one is that you mentioned the pregnancy, right? So talk about pregnancy and breastfeeding, and then we move to a different group. So DMARD in pregnancy and breastfeeding had to be very careful. And let me repeat, very, very careful, because it depends on some medication. Some of them are very bad for pregnancy. Perhaps you heard about methotrexate, right? Or
Yep.
leflunomide. Those are never, I would say, never should be used in pregnancy because they would severely impact the baby. So there's only few of drug that we can use in terms of pregnancy or breastfeeding, and the two most common one we use by far is sulfasalazine and hydroxychloroquine. They are generally considered safe during pregnancy compared to biologics or other targets DMARD that we mentioned about.
Okay.
One thing about those drugs is we have so little or very few study about DMARD in pregnancy or breastfeeding. So I highly recommend you to discuss with your rheumatologist, because in each patient they may have different circumstance, and we have to base on individual to make an individualized treatment.
Okay. So in with the DMARDs, uh, how do you monitor progress?
Well, a couple of ways what we can monitor. The first one is how the patient feel, or basically the disease severity after they taking medication. But just like we ask anyone, how do you feel after you've taken this medication? So that's one way that we monitoring them. The other one that we usually we monitor is we look at their labs.
Yep.
And labs, it could be complex in rheumatology in general, or in spondyloarthritis, because sometimes lab may not match your symptom. I don't know if you've seen this.
Oh, but please, yes. I think most of us have.
Yes, and and, and you know what? To be honest with you, sometimes the doctor may look at, oh, you know what? You have normal lab, but you have pain. What happened?
Yeah.
In my opinions, I always treat humans. I always treat my patient, Joe.
Yeah.
I told my resident and my fellow, we do not treat numbers. We do not treat image. We treat humans. And the humans sit in front of you right now, right here, and complain to you in pain. And you say, ma'am, your lab are normal. I don't know
Yeah.
if you see this, but I do saw
Yeah. I
it.
think I think you could probably say a high percentage of, at least I know for sure, women have had that. Well, and I think this whole conversation is part of why we're at a 7 to 10 year diagnosis.
Exactly. And this conversation will also bring me another point I'd like to share with you guys.
Yeah.
They may have other reason why they're in pain. And we need to look at the whole picture. Well, you're right. Maybe your lab does not indicate you have rheumatoid arthritis or whatever, but you in pain, I'm still trying to find you in pain. rather than say, hey, your lab look normal. That doesn't mean you don't have it. So
Right.
that's one thing I like to share with you, that lab is one part, but not everything. So we talk about clinical assessment. We talk about physical exam. We do an exam to look for your joint. We look for synovitis. And one thing about spondyloarthropathy is we call it disease activity score. I'm not sure the society. Yeah, the data. Yes. So we
Yes.
use it a lot, and with your BA or BASDI, and this is often we measure how much your disease is well controlled or not. So the patient pain and outcome image study, we talk about that, lab included. And sometimes you may have normal labs or normal image, but it doesn't mean you don't have the disease. You
Right.
just, right?
So this is the idea of longitudinal watching over a period of time
Yes.
to see. Okay.
Yeah, and one last thing, Jill, I really want to focus on patient communication. From my
Yes.
experience teaching with the resident and fellows, the patient should understand as much as they can about the disease, because I like to have a shared decision making. This is particularly important for rheumatology or spondyloarthritis, because the patient, once they motivated, they understand, they can help the physician control the disease better. So communication is one way that I can use as a tool to follow up to assess my patient. If they can tell you well about the disease, they understand about the whole progress. They can tell you, oh, Dr. Tran, I'm on 5 milligram steroid today, but I will try to cut down next time. I know she know what it is, right?
Yeah.
Rather than someone, oh my God, I'm just keep taking 40 prednisone or prednisone every day and I have no idea. Can you imagine those patients? So those are come with side effect,
Yeah.
and the communications between the provider and patient is crucial.
So I know with DMARDs, particularly the conventional, uh, how do you talk about risk associated with them? And I know more about methotrexate than sulfasalazine, but like, what are the risks? And I know, how do you work to evaluate them with the patient?
Thank you, Julius. So DMARD, they have some potential side effect or some risk. Depends on the type of DMARD, particularly for each drugs. Each patient may have a different risk. Now, let me share with you some risks and some common side effects that some medication that we see every day. Methotrexate, for example. The most common side effect for methotrexate, nausea, vomiting, fatigue. It basically anything with GI problems. But also it may affect liver functions and it may increase the liver enzyme. Now, whenever I see those side effects, for nausea, vomiting, we use medication or we ask the patient to take smaller dose. I'm not sure if I told you that, Jill. Sometimes if a patient can divide the methotrexate dose in two doses, I'm not sure if
Oh,
you did it before. For example, 20 milligram or 25, right? You take 10 and 15, 10 in the morning, 15 in the afternoon. That could reduce substantially side effect.
interesting.
If you take all of them one time, oh my God, I will tell you that may not be for some people they just say, oh my God, that's too much. So I ask them take two and then they feel better. I say, oh, okay, it's still within the same day. Please do not take every day. Okay.
Yeah.
Some patients they for some reason they misunderstanding they take methotrexate every day. No, that's not cool. Okay. Sulfasalazine is another common drugs and that they cause GI problem, abdominal pain, diarrhea. And then you take those medication with food or you can take with a full glass of water and that can reduce the side effect. And make sure you check with your liver functions and sometimes sulfasalazine can cause some skin reactions.
Oh,
Yeah, leflunomide um, can also cause diarrhea. liver enzyme. And also, this is, I would consider, one of the very potent drugs. So make sure you ask your rheumatologist before you use, because hair loss, I'm not sure if you heard about it, Jill. Hair loss can occur in leflunomide.
Really?
Yes. And what?
I think of all the drugs out there, and like no drug is bulletproof, right? No drug doesn't have some side effect.
There,
Uh,
I will tell you, Jill, unfortunately, that's why I love rheumatology.
yeah,
it's
right. It's like being a detective.
it's yes, you said amazing, and sometimes my hand are tight because I look around, I say, "Well, this drug has this side effect, this has side effect." I have nothing. I have no room to move
I know.
forward.
I
But
remember methotrexate when I decided to stop taking it because I was feeling better, but I also was like, I'm just tired of not being able to have a few beers.
you're right. And
Because
one thing about methotrexate, I don't know, I told you. I don't know. You heard about subcutaneous methotrexate injection?
yeah, I did injections.
Oh yeah, that's even better because you avoid most of the GI things.
Yeah,
And so that's something that people often forget. For example, so even one drug, you can see you can divide in smaller dose. You can take with food. You can take a full glass of water. There's a way to improve the side effect rather than say, oh, you know what, let's stop it. I don't want to take it. And
yeah,
because of that, the disease may progress and it may worsening. So those are things for okay. One thing about plaquenil or hydroxychloroquine. This is one of the best DMARD out there. I would say the best because it's very safe. However, you should check your eyes. I'm sure you notice your eye, right? Because it may cause retinal toxics and
yeah.
it can lead to vision problem. So please have your eye exam regularly, either yearly or more often as needed, because the sooner we detect the toxic to the eyes, we can stop the drug and we have some effective treatment rather than wait until very late and then the toxic to the eye too much, it become irreversible. Now, other DMARD, Jill, we talk about biologic, right? So make sure that those sometimes the side effect include infection.
Right.
Remember, infection means whenever we have a bacteria or a virus, and then we send out the signal to ask for help, right? What if we block those signals? So the body have some invader, some intruder, but we don't call for help. So that's why the risk of infections increase
Oh, yeah.
substantially. You see that, right? So
Yep.
that's why the risk of infections increase substantially with biologic. And what are they? So I ask my patient to have, we call pneumovax or pneumococcal
Yep.
vaccines, right? And then whatever vaccine, please do a flu shot. Vaccine, please update with your vaccine because this is how we protect you.
What is your
Now,
thought on the new? Should people get the new COVID vax?
that's a great question because this is how I see. We should base on individual patient because with the study I saw, and you mean the booster one or the previous one? Which one?
There was the first ones, then the booster ones, and now we're getting into the new one, right? Isn't there?
That's right.
There's a new one coming out in about a month, right?
Yeah, the new one I don't have enough data, but the booster one basically what they do is they change the footprint a little bit about the how SARS-CoV they evolve. So the booster one I can say in case of high risk patient it's still okay. However, the way that I see, we need more data.
Yeah.
I don't feel we have enough data. I don't know if you feel it, but I read and I could not find enough data. And I understand in COVID-19, we are in such a very unique situation. We don't have anything, let's put it this way. And then
Right.
with such a small data, we make decision. And the original one help. I myself have the vaccine one for the original one. But for the incoming one, I don't know yet. I have to see more on what it is.
Yeah. Well, and I think just like with anything else, uh, Okay, I will say I'm not advising anybody to not get it. I'm advising people to talk to their doctor and make the right decision. Uh, but I think too, it does become individual, especially when you've got, because there are some medications that are affected, there are some diseases that are more affected, some comorbidities that are more affected by the vaccine or COVID. Um, and I think when you talk about the data, we're looking at the vaccine, right, as the sort of a yes, no, did it work, not maybe all the causal factors that caused it to not work. Uh, okay, so we don't need to get into that rabbit hole. Uh,
I think one thing we agree. I think each patient should be treated individually.
yes,
That's how I see it. I mean, no matter who will come, whatever, I look at them individual. I say, hey, this patient with this risk factor, what are the risk factors? I mean, what medication, what condition they have, and what medication they on at the moment. I don't. To me, medicine is not about one size fit all, and everyone know this, right?
yeah,
So that's the thing. If you need to have a question, talk to your PCP or your rheumatologist, and they usually have the really good answer for you because they know you the best.
yes. I just don't want any rheumatologists calling me and saying they heard on SpondyCast that people weren't supposed to get their vaccine, because that's not what I was saying. Uh,
Okay.
so one question I have, and then we can probably start wrapping up here, but the idea and the hope, the outcome is with a DMARD is that a better quality of life. Yes. So while on DMARDs, do you have to modify it all? You mentioned you use a DMARD and add physical therapy to add mobility, maybe. Is there anything people should stop doing, slow down doing?
There are things that I would not. First of all, there are things that we should not stop doing, and I consider those are good habits. And perhaps you already know those already. One thing about DMAR and other medication in general is once you take those medication, please do not stop your good habits. And what are they? Number one, exercise. This is one thing that I told my patient again and again. Exercise can be a really good medication. And you know what, Jill? It's free. It has almost no side effect. And what? Not just exercise. Exercise can bring all the hormone to make you happier. So I can tell you all about exercise and people underutilizing this
Yes.
because lifestyle, exercise, those are the key component to fight with spondyloarthritis. So that's the good one. The other good one is networking. So I don't call everyone to participate in this society, but this is a great society, Jill. Let's do this way. So
Okay.
every patient or family member should at least listen to this or know about this website. This is based on research because when we networking, we know and we share, make us happier. And when
Yeah.
we happier, we create hormones like oxytocin, right? And then other hormone, dopamine, whatever, to make us fight better with inflammation.
Right. And it
So
doesn't it also so I remember reading an Alzheimer's study that people who are social, the more people you meet, the less likely you are to have Alzheimer's. And I don't know if that still holds true, but I think about, even there was a lot of discussion around, and we've had this conversation on SpondyCast about pain and rebuilding neural pathways. And I bet networking helps. I think networking does help you to rebuild neural pathways, but I wonder if it helps around the pain pathways too.
it's true. It's actually very true with those, um, not just Alzheimer, dementia, or rheumatology problem. I think with even with cancer. So all the things that involve the immune system and everything that we think about in terms of supportive care, networking, psychologically laughing, those kind of things that
Yep.
can make people feel much better. You see, Jill, the way that I do rheumatology a little bit more holistic because I emphasize on those factors
Yeah.
because exercise, you control your weight and can let me tell you a bit of a weight. Weight is important in terms of spondyloarthritis. Even if we can reduce a few pounds in case of we are overweight, that can make a big difference. Think about you put 5, 10, or 20 additional pounds to your back. Have you ever carried that, Jill? Carry that?
Oh, yes, and I've carried 2 children, so I remember that
How do you feel?
vividly. No, and I will say, and I don't want to caution people to be too thin because I think that, right, or like it's healthy. It's not about, right. I always say I want to feel this good when I'm 80, and some of that is about just maintaining, right, healthy habits. At the moment, I'm a bit of a slacker this last couple of weeks, but I'll promise I'll get back on the train. And water. What do you think about water? I ask this question a lot.
What?
How important is staying hydrated?
Absolutely, it's really important because water is it's the atom of life, right? And water play a crucial role in your college. I don't know if you know this, but when we age, unfortunately, the ability to retain water in college substantially reduce.
Really?
Yes, if you think about it.
Okay. I
And
believe it. You're
you
making me
check
drink
your
water
water, you know what? I'll drink water with you.
Cheers. All right. So we should be wrapping up here soon.
Yeah, but one more thing about those.
Yeah.
Let me emphasize a couple few more. So we'll talk about physical activity, good habit about. Now, two things. Smoking. If you can quit smoking, that help a lot. I will tell you, smoking is detrimental to spondyloarthritis. It will kill your joint. Let me repeat. Please do not, if you can, quit smoking. And then lastly, alcohol. Alcohol consumption can interact with certain medication and can potentially worsen symptoms. Other factor, Jill, can make you a really good patient to fight with spondyloarthritis are good rest, good sleep, and then lastly, patient education, right? I just told you earlier, become an educated patient will substantially control your symptom because you know what are you dealing with.
I love it. And I will say anyone can go to spondylitis.org for more information. We'll get a plug in there. Well, this has been fantastic. So I have one final question, and then I will let you get back to your day. What biggest thing do you find hopeful about the future for people with AS?
Well, the biggest thing that I feel really hopeful about the future is we live in today medicines. That means we have thousands of clinical trials, we have scientists, we have physicians work around the clock to fight, to understand the immune system, to understand about spondyloarthritis, why we have this, and find the best treatment for you. I just told you, right, Jill, 5, 10 years ago, we did not have target DMARDs. 20 years ago, we did not have biologic DMARDs. And as we're speaking today, we have 10 of them waiting for approval from FDA. And I can tell you, the future is so bright. All we need is just put them together. We need a network. We need a good communication. We need to connect our patient with our clinical trial. We need patient to connect with good rheumatologists. We need patient to connect with good pharmacy. And that's it. And we need a good communication on social media, right, Jill?
Yeah.
People understand better about this condition. So hopefully, everyone will always can be beneficial from this advancement of science.
I love it. Okay, so people can find you on YouTube, yes,
Yes,
at the real Dr. Win Tran,
yes.
and on Facebook. Thank you so much. This has been wonderful. You framed it in a way that I finally understood it after 10 years of not knowing enough probably about DMARDs. So thank you for that. And really thank you for your commitment to the community. It's been great.
Jill, I hope we can continue, or if I can be helpful to anything to you guys, to the society, I would be would love to.
Yeah, wonderful. Thank you so much.
Thank you so much, you.
SpondyCast was made possible by donations from the Spondylitis Association of America's individual members and our show's corporate sponsor, AbbVie. Since our founding in 1983, the Spondylitis Association of America has been the face, voice, and leading nationwide nonprofit educating, empowering, and advocating for people living with spondyloarthritis. Through our extensive work with patients, the medical community, and partners, we provide information and resources to help people impacted by the disease live better lives and champion research to find a cure.